distinguished guests, speakers, and participants. On behalf of the organizing committee, I warmly welcome you to today's joint workshop titled Nutritional Approaches for Preventing Type 2 Diabetes and Non-Communicable Diseases in Malaysia, an encounter with NNEdPro and UNICEF East Asia Pacific Regional Office, EAPRO. This workshop is hosted by Universiti Kebangsaan Malaysia's Pusat Idea and the Faculty of Medicine and organized together with NNEdPro Global Institute for Food, Nutrition and Health with a guest speaker from UNICEF EAPRO. We are honored to have with us today Professor Dr. Chim C. the recipient of the Tuanku Muhriz Royal Chancellor Chair at UKM, who is with us today to give us the welcoming speech and also to moderate the event. Without further ado, let's begin the program with a few words of welcome from Prof. Chim. Prof. Chim, the floor is yours.
Thank you, Prof. Poh, for your kind introduction. A good afternoon to everybody here, but good day to everybody that's dialing in or listening in from across the world. I'm really excited about this first joint meeting between UKM and NNEdPro, and in this first joint meeting, targeting NCVD and diabetes. Could I have my slides, please? Next slide, please. So I'm a cardiologist, and I'm reminded, can I have the next slide, please? Yes. So as I said, I'm a cardiologist, and I'm reminded that cardiovascular disease and NCVD is a global disease, but Malaysia is at the epicenter of this global pandemic. In Malaysia, someone dies from a heart attack almost every 50 minutes. And as you can see on the figure on the right, in terms of principal causes of death in 2023, ischemic heart disease feature very, very highly. Next slide, please. What is also very striking about Malaysia is this is data from the NCVD ACS data, and it shows clinical presentations of patients presenting with acute coronary syndrome that includes heart attacks. And you can see the average age of someone in Malaysia with an acute cardiac event is 58 years of age. This is very striking because it is very early. It also affects individuals at the height of their career, impacting not only on themselves, but also on the family and the community. What is also striking, as shown on this slide, is 20% of them are less than 50. This is really striking numbers. Next slide, please. So in terms of NCVD and NCDs, these are the disease processes, the risk factors that we all are familiar with that can lead to atherosclerotic disease. And almost 2.3 million adults in Malaysia live with 3 NCDs. And striking figures as shown on this slide. Next slide, please. When you include, next slide, please. When you include 4 NCDs, then it's over 500,000 people. And what is really looking around us in Malaysia, and we were just talking with some of the people in the audience, is the growing pandemic of obesity. These are figures based on BMI of 25 kilograms per meter squared. Almost 50% of people in Malaysia have a BMI that's greater than 25. And there have been a number of studies trying to explore what is the reason behind this. Personally, I think family history has something to do with it. But as shown on this slide, rather busy, but it shows the work that has been shown to try and tease out what is it that leads to this increased chance of CVD. And you can see some of these studies have shown that nutrition and eating is a key part of it. So I think it's very timely that we have this workshop. We have attendees from across Malaysia. I've just heard someone has come down all the way from Greek in northern Perak, which is impressive. But we have attendees from across the world. So the take-home message is NCDs, cardiovascular diseases. Malaysia is in the epicenter of this global epidemic. Really to fight this, I think it's important to confront nutritional aspects of this, nutritional approaches. So we have a fantastic panel of speakers, really world-class and world-leading. And I'd like to introduce the first speaker. In many ways, I would ask him to introduce himself because he is, to me, he doesn't need introduction where I am, but I think it's important that, Shimon, why don't you tell us about yourself?
My slides. Hello, very, very good afternoon to everyone. Selamat tengah hari, tuan-tuan and puan-puan. Terima kasih. Thank you very much for coming here. And I know this is quite a busy time of year with lots of classes starting up. So extra special thank you to people for making this time. So I'm here on behalf of the NNEdPro Global Institute for Food, Nutrition and Health. And we're going to be talking to you today about prevention to intervention at this important moment as we stand 5 years before the 2030 goals. To introduce myself, so I'm Sumantra or Shumon Ray for short. So I've been a licensed medical doctor and a registered public health nutritionist for a quarter century now. And since 2008, since I've been in Cambridge, I've been leading what is now known as the NNEdPro Global Institute for Food, Nutrition and Health, which actually had its origins in the Medical Research Council's Human Nutrition Research Unit and the Elsie Widdowson Laboratory. And I see suddenly in the audience a colleague who worked with us in Cambridge at the Elsie Widdowson Laboratory who, hello, who has made it here. So that is incredible and amazing. So also for a number of years, I've been leading the BMJ Nutrition Prevention and Health Journal, and I hold a national tenured chair in global nutrition, health and disease, which is hosted by Niche in Ulster. There are various other declarations of interest. You can see that my role spans academic institutions, clinical organizations, and also healthcare research and publishing. But later on in today's program, I will be wearing a second hat once we've heard from our speaker who is joining us online from UNICEF. I also act as an expert consultant to UNICEF in Southeast Asia and also the Asia Pacific region, and we will be elaborating more on that later. So that's just a little bit about my own background, but I just wanted to say special thanks to Professor Lang and Professor Poh Bee Koon for hosting today and contextualizing today's program to priorities at UKM, but Malaysia more generally. As you can see, we have a lineup of various other speakers. I'll be doing a little bit of a double act with Nikki, who will introduce herself later, followed by Helena, who is undertaking a PhD with us. And then we'll be joined by Sanele from UNICEF Online, and finally Professor Mustafa, who is a well-known expert in this region. So once we have actually had some chance to take questions and have a bit of discussion, we'll break and then come back for some interactive exercises. And one of those exercises will be around nutrition education competencies, particularly for the ASEAN region. And another one will be a comparison of gaps and opportunities across 3 ASEAN countries, particularly pertaining to type 2 diabetes prevention and systems thinking. So without further ado, I will jump straight into my part of the presentation. So I think we're all faced with several global challenges, and these global challenges are dynamic, they are geopolitically fluid, but some of the common denominators of global challenges continue to be how we address the wider determinants of health.
We'll take a pause at this point of the recording once we resolve this technical problem. We'll take a break. It seems that there's a concurrent session going on in another part of the building, and this is all right. Every day. So that is a hospital-wide announcement. So that has finished. So Shimon, please proceed.
So I believe that announcement was actually pertaining to some of the wider determinants of health, so how appropriate. But now refocusing on nutrition. So some of you may be aware that the World Health Organization actually hosts a Nutrition for Growth Summit, and the last summit was in Paris just a few months ago. And you can see that this is a summary of kind of 10 needs which were defined in the summit. I'm not going to go over all of them, but we still have a need to address the different forms of malnutrition. And this is a dynamic need because tackling undernutrition and what is often known as the double burden with under and overnutrition and the overlay of micronutrient deficiencies within the same individuals during a life course and in a complex pattern within the same communities, this requires quite a dynamic compass in terms of how to mobilize what we know from research to education to practice and also formulate responsive policies. But the important thing to note here is that one of the outcomes from this year's summit is that UN member states pledged nearly 28 billion to integrate nutrition into broader development strategies. And amongst those UN member states are also ASEAN nations, and that, of course, does include Malaysia. So we as a global institute have also made commitments in the N4G summit, and those are made through the Global Nutrition Report so that those commitments can be monitored on an annual basis. So it's very important for us to take stock of which countries have made different commitments so that we can also work cooperatively across borders and particularly in neighborhoods. But in doing so, I think we need to be as interdisciplinary and intersectoral as we possibly can. And some of the key agreements really have been around food systems transformation on one hand, the appropriate use of technology and innovation on the other. So really going from the bigger picture to the precision of personalized nutrition and nutrigenomics, but also thinking about the whole health system. And we'll hear later from Helena about systems thinking, so that we're actually thinking about how to integrate interventions into routine healthcare systems and practices, as opposed to adding on. And eventually having supportive policies, but as I said a moment ago, policies which are dynamic and responsive to changing threats and opportunities. So this takes us from being intradisciplinary, which is something that we are often very comfortable with, particularly in the biomedical sciences, all the way through cross-disciplinarity to transdisciplinarity. So we see the role of the NNEdPro Global Institute as being a connector of different disciplines. And you can see our UK map on one hand, where we have hubs of activity, particularly in Cambridge and London, and also in Northern Ireland and the east of Scotland. But our global map, which actually allows us to think about spread and scale of common ideas which help with common problems to find common solutions. So if you'd like to read more about how we are proceeding towards the 2030 goals, please do scan this code. And this has a number of case studies which tell you about how we are thinking of democratizing nutrition for all. And that little photo that you see in the map there, so that's a place which is near where I grew up in Birmingham. It's called the Spaghetti Junction. So when you look at it from afar, it looks like spaghetti, very kind of complicated, but actually it's not complicated, it's complex, because the Spaghetti Junction makes all of the road systems between the north and the south of England work, and that's how we see connecting communities and also connecting knowledge.
Hi, we are NNEdPro. We as an organisation aim to tackle global malnutrition and hunger through nutrition education. Since the problem is complex and multifaceted, we also have different roles to play in the efforts against malnutrition. Here's a look at what we do. As a social enterprise, we run ventures and initiatives to contribute towards nutritional equity and population health in the community, and we support related initiatives aimed at social impact. An example is the Mobile Teaching Kitchens initiative. Also, under this role, we work towards direct action, such as establishing the International Food and Nutrition Trust and the Social Impact Incubator, supporting the growth of ideas that will contribute to the fight against malnutrition. As an independent research institute, we conduct studies on nutrition, health, and population-related issues that inform the organisation's insights and interventions. To support that, we co-own the BMJ Nutrition, Prevention and Health. We also convene several research hubs, such as the Human Interventions and Observational Studies Hub and our Data Science and Evidence Synthesis Hub. During the pandemic, we ran a COVID task force to provide the public with relevant health resources. As a global institute, one of our roles is that of a training academy, using our institutions to pass on knowledge, skills and training to healthcare professionals seeking to learn more about nutrition. NNEdPro provides open access learning resources, graduate and career forums, and hosts an international summit, a summer school, and a virtual learning environment for our students. NNEdPro also acts as a consulting body and provides advisory services to external organisations, ranging from local, national, and government bodies to academic and corporate organisations, facilitating them to undertake research, implementation, and training. Through action-orientated research and solution-focused consulting, we aim to embed good nutrition practices into education, as well as into food and health systems across sectors. We have joined forces with academic and specialist organisations to maximise our impact and ensure our collective expertise guides our ventures. With the combined impact of these four approaches, NNEdPro utilises nutrition and health education to achieve our goal of seeing a world free of hunger.
So really over the past 17 years, under this NNEdPro Global Institute banner, we have 9 other subsidiary initiatives, and all 10 organizations work in tandem Actually, 7 of these organizations are focused on different aspects of human nutrition, but have different complementary functions, and 3 of them work across broader areas of population health. But today, the way this entire ecosystem operates is through 10 regional networks, which have a hub and spoke model, and therefore there are more than 1,000 members organized under an academy, bringing inputs from over 80 countries and counting. So the mission is really to look at some of the gaps and opportunities for implementation, to develop evidence-based actions, and to then mitigate some of those problems either through providing evidence-informed education or through creating research and evidence which can influence policy as well as practice. In doing so, we heavily utilize the knowledge to action model. And in fact, we sort of start a lot of our research somewhere in the middle of this ladder that connects the basic sciences to population health. So we undertake human intervention studies, which are physiological in nature, which go all the way through epidemiology to societal context. And as we go up this ladder, there's an increasing wedge of information that we can translate both for policy and practice. And of course, once we have translated that knowledge, we can evaluate further by actually measuring impact, looking at what works, what doesn't, and then of course going back to the beginning to improve implementation through the cyclic process, ultimately leading to sustained knowledge use and where possible also spread and scale. So some of our research looks quite similar to what would be done in a university department, and our human interventions hub is hosted by Ulster University, where we undertake both interventional and observational studies. We have a focus on looking at cardiometabolic risk primarily, but also cancer, cognition, and the liver. We undertake professional studies, which are to do with moving knowledge, attitudes, and practices in 3 sets of target audiences: professionals, policymakers, and the public. And we also have the opportunity to host a range of interdisciplinary and often international PhDs, and also undertake studies in some of those global challenges that we talked about. So this gives us a very lateral lens from molecules to mankind. And that in many ways reflects the nature of human nutrition, which actually goes from the micro to the big picture. In our evidence synthesis, we have a specific emphasis on causal inference and evidence synthesis that actually enables practice by bringing together the strongest evidence on different causal pathways. Our data science is more exploratory, and we have access to a number of different cohorts. One that we particularly have enjoyed working with over the past 12 years is the 1946 British birth cohort, and this gives us a very detailed set of data which actually collect dietary practices or patterns over the entire life course over 8 decades, and there are a number of different health outcomes that we can explore. We, with those evidence synthesis and data science clues, can then design mechanistic studies where we can actually particularly look at physiological and clinically relevant outcomes. As I mentioned, cardiometabolic outcomes are one of the key areas that we continue to look at. So there is a state-of-the-art human interventions study unit hosted in Ulster, where we also run a vascular nutrition platform, but we're also able to look at outcomes relating to a number of other body systems. Our journal is particularly keen on linking both primary and secondary care, and this is an opportunity for us to also instigate more research through the immense network that the journal has across borders. And speaking of those borders, we also have the ability to hear from people in all of the regions that we operate in, particularly through our online program of webinars and journal clubs, through the International Academy of Nutrition Educators, which again has a very multi and I would say interdisciplinary audience. So armed with those different virtual pieces of kit, we also run an independent research registry for food, nutrition and health. And this is to minimize silos in the field so that we can actually know what is happening, what is coming, and promote collaboration between researchers and authors even before full papers have been published. And then, of course, there is the matter of capacity building, where now for the past 11 years, we've been able to bring audiences together. The pandemic silver lining here being that we can now do this hybrid and virtually in order to give people a common understanding across a foundation in applied human nutrition. And this has been quite incredible as the alumni of this capacity building certificate are actually really change makers that have gone far and wide and have done incredible things with some of that common understanding. But alongside this entire journey, we have also been focusing in parallel on the state of play in medical nutrition education. And this has led to a number of different studies and publications, ultimately leading to a curriculum framework in the UK, which has now been mirrored across 6 countries. And really thinking about the levels of prevention, one of the key findings from our work over the past years is the adequate segmentation or appropriate segmentation, I should say, of nutrition knowledge, which is really important when we're thinking about primary versus secondary and tertiary prevention. And that, to an extent, has been achieved through some recent resources that we've developed, particularly our Nutrition in Medicine and Healthcare guide. And we have a sample copy of that here if anyone would like to come and have a look at it, that actually covers all aspects of nutrition in secondary care using a systems-based approach. But with the British Society for Lifestyle Medicine, we've also curated all of the nutrition content for primary care, therefore giving us that continuum from primary through to secondary. But reaching policymakers has been another important goal. And in 2019, with the WHO, we were able to put forward a global architecture paper for the nutrition training of health professionals. And you can see Helena is one of the co-authors of this paper, and she will speak a little bit more later on some of the contextualizations of that to type 2 diabetes. But really, it's an instrument that can be applied in various different contexts. And we've continued to liaise with multilateral organizations and other organizations that provide levers into policy and implementation. And in 2021, we had the privilege of co-authoring the nutrition chapter in the ASEAN Outlook Development Report. And here we are almost 5 years on, and it's really a pleasure to be able to look at how we can pick up some of the recommendations and actions and work with the brilliant colleagues in this region to think about how to bring that to a systems level. And finally, to kind of begin to consolidate our scope of work, we hold an annual international summit each year. We've had 10 summits which foster policy dialogue, and some of those dialogues are sustained. This is an example of a forum which arose from our previous summit on democratizing food and nutrition, which deals with not only democratizing but decolonizing food and nutrition from science to society. So this forum will now continue to monitor progress in this particular area on an annual basis. And this has been an incredible space for different regions to come together, those who have a colonial history and even those who do not, to learn from one another and look at what the process of decolonization and democratization truly means for their regional context. So our next summit is from the 10th to 13th of December, and through UKM, we'd be very happy to provide information on how you can join us, but do scan this QR code if you'd like to know more about our summit at the end of this year. This particular event today is considered to be a satellite event of our summit. We have several satellite events running into the summit. The next one is actually on precision nutrition in Northern Ireland. And there'll also be one on nutrition and sustainability in the margins of COP30 in Belém. For those who might consider going to Brazil, but the important thing is all of our summits are actually hybrid, so there can be participation from around the world. But going from knowledge to action, I just want to give you one quick case study before I hand to the next speaker on how we take all of this and work at ground level to empower individuals by building scalable models and integrating nutrition. So this is the story of the Mobile Teaching Kitchen International Initiative. So the University of Cambridge was the first to receive a global research challenges award in 2017, and we held the nutrition component of this award. And you can see that this is very interdisciplinary. It took India as a case study, and from within that arose the Mobile Teaching Kitchen model.
Malnutrition in all its forms remains a major cause for concern worldwide, creating an intertwining and overlapping burden on individual, public, and economic health. Additionally, in the wake of COVID-19, deep fractures in food systems have been exposed. Here arises a need for a multifaceted solution to create long-lasting systemic change. The Mobile Teaching Kitchen initiative was contextualized with this in mind. As a mobile teaching unit, the initiative recruits members of marginalised communities and travels to festivals, institutions, office areas, and other public gathering spaces to reach out to people through highly nutritious yet affordable food whilst providing nutrition education. Apart from functioning as an affordable pop-up or food truck service, the Mobile Teaching Kitchen provides knowledge about dietary practices, access to lower-cost healthy diets, and associated information on adopting healthier nutritional patterns, thereby improving food and nutrition security. The initiative trains participating members from the local communities in entrepreneurship, nutrition and culinary education, and empowers them by helping them run the MTK food service as a micro-enterprise. With further scalability of the model within India, Mexico, the UK, the US, and further worldwide, we hope to achieve significant and sustained impacts on the number of vulnerable groups positively impacted by the initiative and strengthen community resilience against malnutrition.
So just to let you know, that's not the voice of AI. That's my PhD student from Cambridge, Jodie Webber, who just finished, with very few corrections, her thesis on the Mobile Teaching Kitchen. But really what it is a community hub for malnutrition prevention, health promotion, disease prevention at large, where a different approach is taken by training some of the most marginalized individuals in a given community to actually become micro-entrepreneurs and culinary health educators. So they are not only improving their awareness, they are actually preparing fresh, healthy, tasty, low cost and sustainable foods in the form of nutritionally complete meals based on menu templates, which in a single template contain almost all of the day's micronutrient requirements and also 2/3 of the day's class 1 protein equivalent requirements and lower glycemic index and higher nutrient value carbohydrates. So those meals are served to communities which run across the board. So blue collar workers, white collar workers, really all echelons of society. And so these women and men in some cases, although predominantly women, are able to actually bring revenue to themselves, their families, to a micro enterprise that then gives back to the community. But one of the side effects of this model is that it improves nutrition knowledge, attitudes, and practices using this see one, do one, teach one approach, where the culinary methods can help circumvent literacy and food literacy barriers. And it turns out this is also a great model for teaching medical students who tend to have shorter attention spans these days and lots more in the curriculum on how to actually translate nutrition knowledge in a very, very practical way for the populations that they serve. There are many, many peer-reviewed papers published on this. I won't go into them, but really one of the other important social excuse me, constructs here is that very often when we think about marginalized populations, there's a kind of intergenerational space that they occupy as victims of society, and acts of charity don't bring them out of that space, but actually giving the mantle to them and enabling them to be culinary change makers for all of us changes them from victims to champions. And therein lies another type of mobility, which is the social mobility of the mobile teaching kitchen. We've also looked at the economic side of this, and there are cookbooks which the women from the mobile teaching kitchen also use as their micro-enterprise products. And inspired by all of this, this has also been translated to indigenous communities in different parts of India. This is the Santali tribal community. This particular paper has changed the Eat Lancet 2.0 recommendations because it has challenged some of the dietary guidelines for sustainable and healthy diets. And in particular, this has also promoted further work in the area. So we're currently working with another indigenous community called the Bega in central India. And all of these indigenous communities are extremely different and extremely understudied. So it's a great model to then take across borders. And this is just a little snapshot of our field work. And across borders, it has gone to Mexico, the United States, and also most recently to the UK. So here is just a little snapshot of what's been happening in Mexico, where our colleagues have also been looking at indigenous populations, forgotten grains, and the Mexican cookbook is just about to be published at the end of this summer, which will be a micro-enterprise product there. In the United States, the Mobile Teaching Kitchen works with marginalized communities in Brooklyn and also in the Bethesda area of DC. And of course, these are two of the most powerful cities in the world, but with deep pockets of food insecurity. And here are some little snapshots of our US Mobile Teaching Kitchen champions who range from students through to kind of retired police officers in the Brooklyn area, so think NYPD. And in the UK, we're working with communities which were traditionally involved in what was the great jute trade between India and the UK. As that trade receded, so did the economies of those communities. And today, some of those communities are reliant on universal credit, but you can see 5 remarkable women here from the east of Scotland who have broken into the gig economy by becoming mobile teaching kitchen champions. And those 2 menu templates, which you see in the center, those are 2 nutritionally titrated meals, which they have sold to hundreds of members of the public in Dundee City at a food festival near where they live. And although those 2 menu templates are entirely different, they are nutritionally exactly the same in composition. And one is Scottish, the other one is South Asian, and that actually is always quite remarkable for the people that they serve. So just to end off my piece, I wanted to say that I'm here with Nikki, who happens to also be my daughter. And she was actually the one who originally came up with the concept of the mobile teaching kitchen when she came with us to a workshop funded by the ESRC in 2017. We didn't have childcare, so she came everywhere, and this is the byproduct. So the MTK was launched in 2018, and then Nikki went further to launch her own project known as the Little Literacy Libraries. And since then, that has been recognized through a number of different international awards. And this is His Excellency President Kovind of India, who also recognized this initiative a couple of years ago. So I'm now going to hand to Nikki to finish this piece before we go on to Helena, so that she can talk about insights from Little Literacy Libraries.
Hello, everyone. Good afternoon. My name is Nikita. I'm 16 years old and a student in St Leonard's School in St Andrews, Scotland.
Please keep the slides.
I have officially worked with the NNEdPro Global Institute since 2018 with the start of the MTK. Through the MTK initiative, which has led me to be the NNEdPro Youth Ambassador, leading the Kids Kitchen Club Challenge through the pandemic and now being the youth voice for both the MTK and the Little Literacy Libraries. So what is the Little Literacy Libraries? The LLL is a project born from the mobile teaching kitchens. It operates at the intersection of nutrition, education, empowerment, and dignity. At its heart, the LLL aims to fulfill multiple United Nations Sustainable Development Goals, including Goal 1, no poverty, Goal 4, quality education, Goal 5, gender equality, Goal 8, decent work and economic growth, and Goal 10, reduced inequalities. The model is simple but impactful. We place bilingual, accessible educational libraries in underdeveloped areas within the communities of the mobile teaching kitchen champions. These libraries are more than just collections of books. They are safe spaces where children can escape, explore, and learn. We collaborate with volunteer teachers, creating a self-sustaining ecosystem of education and empowerment. So why would this matter, and why would it matter to me? My involvement with this project is deeply personal. After the launch of the Mobile Teaching Kitchen in 2018, I often found myself interacting with the children of the MTK champions. I was struck by their intelligence, kindness, and potential, but also by how limited their opportunities were due to systematic poverty. As someone who comes from a place of relative privilege, I realized I had something powerful to offer: my voice, my education, and my platform. That's why I began fundraising at school, gave talks both locally and globally, but most importantly, helped to shape and co-launch the Little Literacy Libraries. So let's take a look at some of the hard truths and realities. According to the International Labour Organization, 160 million children are globally involved in child labour. That's nearly 1 in 10 children. In India, the ILO estimates 5.8 million child labourers. The local NGOs and independent researchers estimate the number could be as high as 30 million when informal sectors are included. In urban slums, over 20% of children aged 10 to 14 are involved in some form of economic activity, many of them in the informal economy. UNESCO reports that 6 million children in India remain out of school entirely, often due to a combination of poverty, gender inequality, and geographic isolation. The children we work with in the LLL are not an exception to these statistics. Many have faced or continue to face economic hardship, early responsibility, and barriers to formal education. Some have pulled out of school to help support families. Others never enter the system at all. Although these children are able to receive a governmental education, there are issues that come from this, as we work in 2 types of slums, one registered and one unregistered. This is not uncommon. According to the Institute of Local Government and Urban Studies, there are 2,011 registered and 3,500 unregistered slums in Kolkata alone. These slums provide housing to more than 1.5 million people. Therefore, whilst the Little Literacy Library provides additional education to many, it provides a baseline for some others, making it dynamic and a necessary initiative. So, a question often asked is, why teach English? It is true, India has over 121 spoken languages and 22 officially recognized languages. Language is deeply tied to identity, community, and heritage, but English in India carries a unique status. It is the language of the courts, many universities, and competitive civil services. In fact, over 90% of job listings in sectors like IT, law, and finance require English proficiency. Those with fluency in English tend to earn on average 30 to 35% more than those who don't, according to the study by British Council. A 2021 report found that in India, English-speaking students have twice the access to higher education opportunities, both at home and abroad. That said, we are deeply committed to linguistic balance. This is about inclusion, not assimilation. So the pilot project and what children really want. In 2023, my school had a community project initiative where students were encouraged to engage in meaningful outreach. I used this opportunity to pilot a data gathering off the Little Literacy libraries. We conducted surveys with children in the community to understand their goals and dreams. Some patterns were striking. The top career aspirations were government jobs such as police officers, teachers, and civil servants. When asked why, most children said security, respect, and helping people. This tells us something critical. Children are not limited by their minds, only by their circumstances. They have clear dreams, clear goals, they just need a pathway to reach them. The LLL becomes the first stepping stone for these children. So why would this work, and why would this specific model work? The Mobile Teaching Kitchen and the LLL function on a shared principle, peer-to-peer education. That is, people teaching people in their own communities. This approach reduces dependency on external aid, empowers local women as educators and role models, builds community trust, and allows for rapid, adaptable expansion. With continued support, this model can scale to thousands, and not just in India. So how is Malaysia relevant to the MTK, which is based in India at the moment, the MTK and the LLL, which is based in India? Earlier in this year, in 2025, Malaysia hosted the Secretariat of ASEAN, Asian Association of Southeast Asian Nations. This means that Malaysia holds a unique and powerful position this year in geopolitics policies. ASEAN aims to accelerate economic growth, social progress, and cultural development in the region, promote regional peace and stability, and foster collaboration amongst member states. This includes multilingual literacy and integration in each state as part of social and cultural development. Therefore, projects such as the Little Literacy Library can be supported by ASEAN to bridge inequalities across the region. So what could the future hold for the LLL? Work in the library is far from over. Within the next year, our goals include to create a sustainable and comprehensive curriculum for the students to achieve, basing this upon positive reinforcement and valuable incentives, and to source more learning materials in order to aid each child. I hope this has taught you something new, and thank you very much for listening.
Thank you.
In the interest of time, we're going to have a Q&A at the end. We're doing not too bad with time. We started late. So next to Helena, can you allow you to introduce yourself, Helena?
Just giving a summary of our activities across the event to our colleagues joining across the world in our group. Thank you to all of you. I know it's a tricky timing to have this event, but I really, do you mind the pointer? But I really thank all of you who have joined and that supported the organization. My name is Helena Trigueiro. I am a Portuguese dietitian by background. I have been living in Belgium for the last 5 years, and I work as my day job full-time in food policy and agriculture policy. But since 2018, a long time ago, I've been collaborating with NNEdPro. I was a candidate at the summer school, and then developed many different areas of work with NNEdPro, and I'm really happy to be here. Also to showcase a bit of different academic endeavors we are going through around my PhD. So I am a part-time PhD student at Ulster University in Northern Ireland, and my area of interest, as displayed, is really how systems approaches can improve policies for disease prevention, mainly type 2 diabetes. And type 2 diabetes was something and a topic that I felt really connected to when we started working on this Outlook report, this ASEAN Development Outlook report that Shimon mentioned. And me and other colleagues, both in local here in the region, but also over the UK, and in my case in Portugal at the time, we were working to give an overview of how, in terms of health, in terms of malnutrition, how we had achieved or not universal health coverage in these many countries. And what we saw was really that despite the great variety of policies and of actions, there was the picture around the indicators and the results across diabetes were really staggering. And I think that speaking, for example, just now with Professor Mustafa, I think it's really clear that this is a disease that we see growing, and she will give us an overview of that, of the reality as a clinician. But really, in terms of policy, there was a discrepancy in terms of the reality and what was being done. And when I started looking into diabetes, as a dietitian back home, I was seeing a lot of scary numbers, very scary numbers. But when digging deeper into the global picture, I was astonished by the numbers that we see in terms of Southeast Asian, Western Pacific, and especially around the predictions. So in terms of foresight of the future on diabetes and the way this will impact communities, it was really staggering to see the not only the present prevalence, but also the way it's going to escalate specifically in this region. And so when looking at this cluster of diseases, chronic diseases, it was very clear from the beginning that we had many initiatives that were focusing heavily on the education part, for example, of prevention, but not so many that would be, as we say, horizontal, more cross-disciplinary, and that would cover so many of these factors that affect the development of diabetes. And this was at the same time that I started exploring by reading this book by Donella Meadows, which I recommend, called Thinking in Systems. I started exploring what was systems thinking and why it could have a role in policy development. So when it came to this book, for example, most of the examples are around mechanical engineering or any other very different areas. But I could see a very clear parallel between what was being discussed in the book and what was being read by me in terms of the challenges of these different chronic diseases. So I started digging into systems thinking, and I think the easiest way to explain the different approach that is systems thinking is that sometimes in biomedical sciences, and speaking against myself as someone who was studying as a nutritionist for many years, I felt sometimes compelled to go into very traditional A plus B equals C perspectives and approaches. And what happened is I found myself reading more into systems and understanding that there are approaches who, instead of going over the complexities and the difficulties, address them in a much more integrative way. So when starting to look into diabetes, it was very clear that there was already at the time some literature in terms of the use of systems thinking to treat diabetes and to manage the effects of diabetes, but not necessarily to prevent the disease. And I found myself having this stone in my shoe that is so much science that I came across about the systems was about the management of the disease, the management of the impact in the country, for example, of the disease, but not necessarily about the prevention. And it was very clear is really there needs to be I would say more of a upfront from the root, from the start perspective on the disease development. And really I saw that, and I think it's been more and more visible for the last 4 years. I've been working on this topic, that there is more research, especially around the modeling and this complexity dynamics of diabetes, and that really show that because the issue and the disease is so complex, that we need complex solutions to address it. In terms of systems thinking, I will not go over the more otherwise, I would not shut up. Trust me, I would go for 2 hours on the research methods of this. But just to give you a bit of a very short overview, there's many research methods verified and used in many different areas that come from the systems thinking perspective. Some take a network analysis approach. So, for example, they would go to different people that work with diabetes, from patients to professors, from doctors, so many of us here today, and understand how they see and they foresee the development of the disease, and we're here from them across different, from their different perspectives. We would have some other modelings where it's more about the analysis of the development of the disease across time, so it's more of a temporal analysis than the network analysis, etc. In terms, when we conceptualize this, so imagine if you're listening to many patients, doctors, parents, for example, of children with diabetes, the way we would conceptualize the development of the disease would be through systems tools. And these are some of the systems tools we use. So we have the example of a diagram, or of a classic loop diagram. We have the stock and flow diagram, which is very similar to the ones used by Donella Meadows in the book I mentioned. Other diagrams which are more focused into boxing the sort of the perspectives shared by people, and some that are more focused on policy and policy structure. So this is the way that we conceptualize what's being said, and that we conceptualize and map the development. And we do this to have a very explicit way to understand, in this case, the development of the disease, and to understand where there are gaps, where we can address more efficiently and more effectively the development of the disease, and what needs to be done. Okay, so this is very cross-disciplinary. I would say that across my project, and as the project develops, these would be my main, these are the main objectives I'm working on. So describing how type 2 diabetes has been tackled across prevention policies from specifically the countries of Malaysia, Singapore, and Brunei. So, and we have worked closely with colleagues, for example, from Brunei, but it would be good also to have more Malaysian colleagues involved. So I'm really open to discuss with you and further colleagues for potential collaboration on this. Then examining policymakers' understanding of systems thinking. So I will go to policymakers and assess if they use systems thinking, if not, if it was a priority or not, and then understand how we can use this. So how we can take this knowledge from these the region, from what's been done, and how to improve. My work also, so I don't go over a lot in time. So you can have the slides. Just I think with the organization we'll share, but just I did an overview of, in terms of policy, about what was being done in terms of policies to target diabetes. And despite obviously we would expect differences in the approach from different countries, but it was very interesting to see the different priorities despite the similar numbers in the development of the disease. And then my second study that I will be developing hopefully very soon is really to explore these views and understanding from the policymakers. The perspective is really to conceptualize and to hear from people, instead of taking an informed approach of just looking at the data and just assuming. So really reflecting, learning, adapting, and having this engagement with people, with patients, to hopefully improve policies and fight diabetes. I think so far, what I can say for sure is that the collaboration between governments, NGOs, civil society, academia, patients is really critical to improve these outcomes. In the beginning, I had more of a typical linear approach to things, and I was very humbled by the knowledge that was coming my way as time went by. And obviously, that I think it has been clear that the prevention of type 2 diabetes really demands systems approach. In 10 minutes, I could not possibly go into these approaches in detail, but it's something that we can discuss in the Q&A and afterwards. But I will be going through deeper studies into how this can be addressed in the future, especially because of the development of the disease in the region, and how it's affecting so many millions of people in the present and in the future. So thank you so much.
Helena, I think there will be a Q&A session. Let's see. Oh, UNICEF, sorry.
Hello, everyone. Can you hear me?
Yep.
Oh, okay. So I'm Sanele Nkomani, from UNICEF East Asia Pacific Regional Office. I'm not sure how the slides will go, but I suppose someone will share my slides. I'm happy to just say next after each slide. But yeah, just a huge thank you for the opportunity to speak at this event, which aligns very closely with our ongoing work to strengthen nutrition capacity among health professionals. We are pleased. Are the slides going to come up?
Just 1 minute, Sanele.
Okay, sorry. Yes.
No worries. If you wanted to say anything else to set the scene in the meantime.
Sure. I can keep going, I suppose. So yes, maybe go back to my introduction and point out that apart from working for UNICEF, my academic background is being a dietitian. So I have a master's degree in dietetics from the University of Stellenbosch. So I feel like I'm in a room of like-minded people. Yeah, thank you. So what we are going to share today, I think the slides are up now. Thank you so much, is to share an overview of a project we've been leading as UNICEF EAPRO, and we look forward to your reflections and your deeper discussion during the breakout sessions, particularly from you as health professionals in the ASEAN region, who are intended beneficiaries of this initiative that we're doing. I'd also like to sincerely thank UKM and our partners NNEdPro for giving us this platform. We regret that we're not able to join in person, but we are very glad to still be part of the conversation online. Next slide, please. So this project was formally endorsed as a concept note by all 10 ASEAN member states early last year. It sits under the ASEAN Health Cluster 1, promoting healthy lifestyles work stream. The initiative also aligns with ASEAN's broader sectoral strategies, including the Strategic Framework and Action Plan on Nutrition and the ASEAN's development agenda. As I said, UNICEF serves as the lead technical partner for this project, with Lao PDR acting as the ASEAN member state that's leading as well. And then we've also collaborated very closely with regional experts, especially from academic institutions. And on the international front, we are fortunate to have partnered with NNEdPro, who are bringing in the additional global expertise to this effort. So as outlined in the concept note, the activities focused on defining core nutrition competencies for 3 cadres, which are the doctors, nurses, and midwives. We're also setting minimum requirements and training standards to help ensure that institutions can actually deliver these competencies with quality. Next slide, please. So why this project and why doctors, nurses, and midwives? As we know, most countries don't have enough nutrition and dietetic experts, especially at the lower levels of health professionals. At the lower levels of the health system. So doctors, nurses, and midwives, as we also know, form the bulk of the workforce and are the most likely to engage with patients needing nutrition care. But what we know from evidence globally and even in the ASEAN region is that they often don't feel prepared to provide nutrition services. And this gap is rooted in knowledge and skills they acquired in pre-service education. In-service training attempts to fill in that gap, but it has its limitations. As this group would already know and has been alluded to several times already, nutrition-related conditions are now the leading cause of death and disease globally and in Malaysia. So this makes a very strong case for training for pre-service capacity building, which is more urgent than ever. Next slide, please. So we started this work by doing a landscape review to get a better sense of where things stand when it comes to nutrition and pre-service education across the ASEAN region. What we found rather was quite a bit of variability in the nutrition content across curricula. So this was both between countries and within countries. And in many cases, the content isn't aligned with national guidelines and policies, and we saw big differences in how deep the content goes, with some essential competencies missing altogether. There were also some quality issues. So there was no clarity on what counts as enough nutrition teaching or practical exposure. And even where nutrition is assessed, it's not done in a systematic way. We also found gaps in practical training is quite limited. We also noticed that many of the teaching and learning materials are quite outdated. And finally, even though though these three cadres are the ones delivering nutrition services in practice, their job descriptions often don't reflect this. So this goes back to what is actually reflected in their pre-service education in terms of nutrition. Next slide, please. So this guideline is really about making sure that the nutrition content and how it's taught is consistent and of good quality across the region. It's also about making sure that what's taught aligns better with the region's nutrition priorities, things like tackling malnutrition and addressing diet-related NCDs. And we are very aware that nutrition is just one part of these very packed pre-service programs, but this work still brings us a step closer to enabling smoother movement of professionals and more exchange across the ASEAN, which supports the mutual recognition agreements. Next slide, please. So this is a very broad outline of the GMS document as agreed in a consultation meeting we had with member states. First, the competency frameworks, which are differentiated by cadre. They all stem from the same foundation, but we've made adjustments to reflect the cadre-specific roles and responsibilities. Today, we'll be focusing on the medical competency framework. And then the second, we have set supporting standards or guiding principles for the quality education, which will cover things like minimum qualifications for educators, teaching nutrition, requirements for classrooms and practicum sites, including infrastructure and equipment, standards of how student competencies should be assessed, governance and enabling environment standards. So this would include who's responsible for the quality of nutrition of the nutrition curricula, options for including nutrition components into accreditation and licensure requirements for these cadres. And then lastly, there'll be a chapter that supports countries in planning for integration of the guidance into their own national curricula and standards, looking across all the quality areas that I've just talked about just now. Next slide, please. So for the medical competency framework, we're proposing 4 competency domains or themes, as you can see on your screen, from scientific principles to public health, nutrition, and food systems. Next slide, please. So a deeper dive into these 4 domains is just an overview of what they would contain. The scientific principles of nutrition focuses on the foundational sciences, biochemistry, physiology, and how these link or how the science rather of nutrition can be applied in clinical application. So that means how nutrients affect health essentially. We've also included competencies around evidence-based nutrition practice and lifelong learning, which is really important since nutrition is an evolving field. And then the second domain or theme is the nutrition assessment theme, which really covers the scope of what a doctor would be expected to do in terms of nutrition assessment. So it includes interpreting anthropometry, doing nutrition-focused physical exams, interpreting or the nutritional interpretation of biochemical indicators. And a big one here is also recognizing drug-nutrient interactions and incorporating nutrition assessments into medical diagnoses and care planning, including knowing when to refer as well to specialists like dietitians. And then the third is the nutrition care process and MNT, the medical nutrition therapy. And then this domain includes applying nutrition across different life stages, but also focuses on the communication and counseling aspects, including behavior change. It covers how to plan, monitor, and evaluate nutrition interventions, and emphasizes working as part of a team. Again, knowing when to refer and how to collaborate with others is key here. And then finally, the public health, nutrition, and food systems. This domain sort of zooms out a bit, looking at the broader influences of food choices and social and cultural factors. So the idea is for doctors to understand these dynamics and be able to integrate nutrition into broader public health nutrition programs. Next slide, please. So this is just a quick what is this framework and what it's not. So it's really designed to equip doctors with the essential nutrition knowledge and skills that they need for entry-level practice. Importantly, we've tried to design these competencies with integration in mind. That way, it's easier for curriculum planners and developers to see where nutrition would fit naturally into what is already being taught. And just as important is what this framework is not. So it's not designed for nutrition specialists. That's a whole different other scope of practice. And while we fully recognize the value of general professional competencies, things like ethics and professionalism, as I said, we've only included those that have a direct application to nutrition practice. So the others, we assume that can also enable nutrition practice, but we assume that they've been covered in the existing curricula. Next slide, please. So here's a quick overview of how the competency framework came together, and this is my second last slide. We've started the competency. We started with a scoping and desk review, including the landscape review that I mentioned earlier. And the idea was to understand where nutrition sits in pre-service education and what services are needed from the public health perspective. We reviewed both nutrition-specific and CADA-specific frameworks, existing competency frameworks, which also helped us see how nutrition could be integrated into existing curricula and how to frame the competencies in a way that makes sense for each CADA group. It's been a consensus-driven process from the start. So beginning with our first consultation with ASEAN member states last year, we've also had an advisory group, including NNEdPro and regional experts supporting the drafting process. For the CADA-specific versions, we've also been engaging directly with some of the member states, including Indonesia, Philippines, and Thailand. And we are very glad now to involve Malaysia in these early discussions as well. Next slide, please. So my final slide is to just talk about the next steps. So the GMS document is currently being drafted, as I said, with plans to share it with all the member states for review by the third quarter of this year. So it will be in your inboxes. We are working with the ASEAN Secretariat to encourage countries to form inclusive technical working groups. So they need to bring in educators, policymakers, regulators, and associations. So this review process, we acknowledge, may take some time. It may take more than one round, but we're aiming for approval of this document sometime next year. And then beyond the guidelines, I think it's important to see the vision. And our vision is to develop the operational tools, including faculty development programs, curriculum toolkits, followed by tailored country-level support for the adoption and implementation of this guideline. Of course, all these timelines are indicative, but yeah, that's the vision. And with that, next slide, please. I would like to thank you very much for your attention to this presentation. Thank you.
Thank you, Sanele. So we'll move on very promptly now to Prof. Norlaila to finish this session before we break out to Q&As. Thank you very much.
Thank you.
Thank you very much, Prof. Chim Lang. My name is Norlaila Mustafa. I'm an endocrinologist. I'm working in UKM for the past 28 years. Can I have my slide, please? Right. Thank you. Right, so I'm going to talk about clinical insights into NCD prevention, but before that, I'm going to share with you the the prevalence of diabetes in Malaysia. So what I'm going to show you has been shown, a bit by Prof. Lang just now. So what we have here is the NHMS or National Health Morbidity Survey 2023, and this is the 7th cycle of NHMS. It started back in 1986. And then 1996, after that 2006, and when the prevalence of diabetes, obesity keep on increasing, then we decided to do it every 4 years. So this is the 7th cycle. For this 2023 data, about 13,666 individuals were interviewed, and the response rate was 83%. So, and we found that 1 in 6 adults in Malaysia have diabetes, about 15.6%. And if you look at the proportion of diabetes, looking at the age group, it is very scary, because you can see here that about 84.4 are actually not known that they have diabetes, and they are from a younger group of population that is less than 30 years old. So when we first started NHMS morbidity survey, we recruited patients or subjects beyond 40 years old. But over the years, when we found that those less than 30 years old have diabetes, then we actually recruited those at the age of 18 and above. So you can also notice that 2 in 5 adults with diabetes do not know that they have diabetes, and 2 in 5 also, only 2 in 5 have glucometer at home, and about 56% do not have glucometer at home. They don't monitor their blood sugar despite having diabetes. So if you look at diabetes further, based on National Diabetes Registry, this is in 2022. National Diabetes Registry was done. It's actually an audit looking at how diabetes being managed at health clinic. Basically, it's not hospital-based, it's clinic-based, managed by primary care physicians and medical officers. So if you look at this, more than 3/4 of them have hypertension, dyslipidemia. They are either overweight or obese. So these comorbidities will then lead to CKD as well as cardiovascular disease in diabetic patient. So like what had been mentioned by Prof. Lang, over half a million of population have 4 non-communicable diseases. And of course, you have been shown the data before that the obesity and abdominal obesity has risen about 10% more as compared to 2011, and about 2 years ago. So increased by about 10%. And what actually contributed to this is 1 in 3 adults in Malaysia are physically not active, and 1 in 2 adults in Malaysia lead a sedentary lifestyle. So it's easy to share with you all NHMS because it's a bigger number, although we know very well that, there are studies looking at prevalence of diabetes in targeted population. And of course, when we talk about targeted population, the prevalence will be even higher. So if you look at what contribute to obesity as well as diabetes is lack of sleep. We know very well that, when you don't have enough sleep, that's where you are stressed up, the cortisol goes up. That leads to obesity as well as diabetes. And 2 in 5 adults in Malaysia, or 38% of adults in Malaysia, are not getting enough sleep. So we also did MSSM study or metabolic syndrome study for Malaysia back in 2007. in which we perform OGTT in 4,341 subjects, rural and urban population, and the prevalence about 18 years ago based on OGTT was 22.9%. So you can see the difference when you use different diagnosis or different method to diagnose diabetes, OGTT, as well as, as compared to NHMS, whereby you only rely on fasting finger prick blood sugar. If you look at the data, MSSM study, Indian contributed to diabetes more as compared to two other main ethnicity in Malaysia, and this is similar in NHMS data as well. Female slightly higher in terms of prevalence of diabetes. If you look at location, about 18 years ago, rural population contributed more to prevalence of diabetes in MSSM study. This is related mainly, I suppose, due to nutrition again, whereby they eat a lot more carbs and they are more of a B40 population. And similar to the most recent data, NHMS survey, about 12.1% do not know they have diabetes until we went and did perform OGTT on them. So if we look at how are we doing with regards to managing diabetes in Malaysia, Diet Care 2008 and 2018, about 17 years ago and 10 years ago, 2018, 1,500 subject with type 2 diabetes with a mean duration of diabetes about 11 years, BMI 27.8 kilogram per meter squared. Only about 13.4% able to achieve A1C of 6.5% or less. This is based on our CPG recommendation. But if we follow ADA guideline, about 22.8% able to achieve A1C of less than 7%. So about 5 years later, the same audit was done. Now this diet care was done in the main hospital, not a clinic kesihatan or a health clinic. So basically the patients were managed by endocrinologists as well as specialists. So 5 years later, about 1,600 subject with type 2 diabetes with a longer duration of diabetes. You can see here that the BMI has increased from 27.8 to 29.1 kilogram per meter squared. And I suppose again with the availability of more anti-diabetic agent within 5 years, as well as more insulin being used by the physician as well as endocrinologist, and more acceptance by the patient, you can see that slightly more patients with type 2 diabetes able to achieve the target that we wanted. If you look at target type 2 target T2D study, sorry. This again was done recently, and the hospital involved were again in Klang Valley, UKM, Sungai Buloh, Putrajaya Hospital, as well as Selayang. So you can see that all these 5 hospitals, the patients were managed by endocrinologists, not general physician. So you can see that about 70% of type 2 diabetes patients fail to achieve target A1C of less than 7% despite the availability of GLP-1, the availability of SGLT2 inhibitors as well. So we managed to recruit more than 5,000 patients with type 2 diabetes with duration of diabetes about 14 years. Now, duration of diabetes may also contributed to this target that that we failed to achieve. At the same time, we know we are managing high-risk patients with type 2 diabetes, whereby if you look at cardiovascular risk, according to European Society of Cardiology, about 98% are very high risk, and 1 in 3 people with type 2 diabetes already have atherosclerotic cardiovascular disease, as well as 30% already had stage 3 CKD. And again, obesity is a big problem. About 80% of our population had BMI more than 25 kilogram per meter squared. Now, about 2 years ago, we already launched our CPG obesity, and we follow the most of the Asian country because of our small frame. The target or the normal BMI is actually less than 23 kilogram per meter squared. So if we follow our new guideline for CPG obesity, then you would see that the figures will be even higher, not achieving target or BMI that we wanted. So back to National Diabetes Registry 2023, this is again looking at audit of how diabetes patient being managed at Ministry of Health clinics or Klinik Kesihatan. So you can, at the end of 2023, about 966 klinik kesihatan or health clinic provided data to the NDR, and more than 800,000 active diabetes patients were recruited in this audit. Mean age of diagnosis was 65 years old. So you can see that in health clinics, the BMI are still not terribly bad as compared to what we see in our center or tertiary center, BMI about 27.3 kilogram per meter squared. And most of them are still on oral monotherapy, dose on insulin about 22.6%, about a quarter, about 1/3 on oral monotherapy only, most of them on insulin. And if you look at diabetes control, they are doing much better than Target T2D study, as well as diabetes or diet care 2008-2013, because they are basically newly diagnosed, not having so much complication. And A1C of 6.5% or less was about 34.4%. Not much difference as compared to NDR 2022. If you look at comorbidities and complication of diabetes, again, similar to 2022, more than 3/4 had hypertension and dyslipidemia. Ischemic heart disease is low, but a lot of them who had underlying heart disease will be referred to hospital-based care or being seen by cardiologists already. So nephropathy based on urine presence of protein in the urine is 12.7%, and retinopathy about 11%. So looking at the whole scenario at Klinik Kesihatan as well as tertiary center, what is then the direct medical cost of managing type 2 diabetes in Malaysia? This is based on 2017 data. So if you look at this data, total cost of diabetes about 1.4 billion per year. But if you look at the complication in people with diabetes, namely MI, stroke, heart failure, retinopathy, cataract, and peripheral vascular disease, about 70% of this 1.4 billion are actually managing the complications. Therefore, it's very important to detect diabetes so early, or even to prevent diabetes. Hopefully that we will be able to save a lot of money managing the complication. And nephropathy actually contributed to most of the money that used for dialysis, either peritoneal dialysis or hemodialysis. So we know very well that what contributed to diabetes is aggregates 11 that leads to hyperglycemia and beta cell dysfunction. And from the data that I've showed or shared with you earlier, we know very well that unhealthy eating, lack of exercise, overweight, family history that you can't change much contributed to diabetes or development of diabetes. And importantly, pro-diabetic lifestyle factors that leads to all these changes, systemic insulin resistance and beta cell dysfunction, and eventually hyperglycemia. If you look back at NHMS 2023 data, obviously, most of our population had pro-diabetic lifestyle. We know that they are not physically active, they lead a sedentary lifestyle in which 84% of adults are not active in sports, fitness and leisure activities, and about 84% do not even walk or cycle from one place to another. So most of, if you drive around, you will see a lot of them on motorbike, so rather than motorcycle. I suppose hot weather contributed to that choice as well. And we know very well, as I mentioned earlier, 38% of Malaysian adults sleep less than, sorry for the spelling mistake, 7 hours within 24 hours. So there's a lot more common in urban area. I suppose everybody has to wake up very early in the morning to beat the traffic jam. And as well as go back very late at night again to beat the traffic jam. But if you look at between men and women, they are all the same. You look at whether socio-economic factors play an important role or contributed to lack of sleep, they are all the same. And another issue that also staring that 95% of adults in Malaysia consume very less fruit and vegetable daily, and that also contribute to when you take or you eat less nutrition in some part, you tend to eat more in other nutrition, especially carbohydrate that makes you feel full faster. Sorry. And this is looking at the prevalence of fruit intake by age group. Of course, and you can see that younger population eat lesser fruits. As you get older, you may eat a bit more fruits and vegetables. So diabetes really a huge problem in Malaysia. If you look at respondent in NHMS 2023, about 60% of them are from B40, meaning they are from a lower socio-economic status, and that contributed to the choice of food. And I think culture and upbringing also contribute to a significant factors in the development of type 2 diabetes. So just want to share with you what my patients drink every day. If they drink teh tarik or tea with milk, you can see here that the sweetness per 100 grams, the calorie is very high, contain high fat and high sugar as compared to fresh milk. Only 63 calories, low fat, low sugar, but the price is double than the sweetener. So that contributed a lot because patients always complain that, the nutritious food are very costly and they will opt for cheaper food that make them feel full faster. Again, if you look at this, excess fat and excess carbohydrate as compared to low fat and low carbohydrate, and excess fat, although, you seem to have this egg here, maybe there's meat here, but, the way it's being prepared. So a lot of education need to be done. So if you look at here, undernutrition and overnutrition at the same time, probably because lack of awareness and education, and also habit that they actually have over the years with regards to choice of food. The prevention of diabetes, we know very well a lot of diabetes prevention study have shown benefit over many years. DPP studies, darking studies, and DPS, as well as the sustained reduction in diabetes in terms of DPP outcome study. And is it possible to prevent diabetes? Yes, I think it is possible. It has to be translated into community with the help of everyone. In Malaysia itself, we have MyDip mobile app pilot study, multiple approaches including weight loss, dietary modification, physical activity, and quality of life. It is doable. This is done by a group from University in Kuala Terengganu. My Manis app, my goddess, looking at prevention of diabetes in a woman with gestational diabetes. Again, a small group study by UPM group. Data has not out yet. I think they completed last year, the study. And pre-diabetes intervention, management and evaluation, prime study emphasize on diet and exercise using mobile app. This is a Sunway group together with Bionime, providing the glucometer and caring pharmacy. So again, the data is not out yet. So all these are small study. There's My Mama study looking at pregnant woman done by a clinic kesihatan. Unfortunately, there's not much difference after that. So we know very well there's a relationship between obesity and type 2 diabetes. Genetics play a role in polygenic disease with regards to diabetes and obesity, epigenetic with regards to fetal programming in the uterus. But what important is environment that leads to a lot of or contributed a lot more to the development of diabetes as well as obesity. So it is possible in terms of preventing diabetes, provided we identify the risk early, can also be delayed, and thus would be able to delay the complication. How are we going to do it? With community organization, schools, education very early, access to healthy food option, safe environments, and available area for physical activity. These are the common complaint by my patients, access to healthy food as well as area for physical activity, and therefore collaboration and coordination is very important with all the stakeholders. So to conclude, diabetes we know is very prevalent. Cost managing diabetes complication is far exceeding the treatment of diabetes itself, and therefore to identify those with risk factors and preventing diabetes is crucial. Younger population, we should aim and targeted them, and we should manage obesity or overweight much early on. Education on healthy lifestyle should be stressed, especially at school and younger population, and intervention in future may also involve pharmacotherapy, including treatment of obesity. And thank you.
Thank you, Prof. I think we've had quite a lot of sessions this afternoon, and I'm thinking aloud what we should do, because I know people are needing a comfort break or something. Should we have a quick comfort break and come back for a Q&A with a fresh mind, thinking that we've had an overview from Ramon, from Nikita, and then some solutions from Helena, Selene, and then, my gosh, what we heard from Norlaila, Malaysia is a time bomb, things are going to happen. So why don't we have a quick 5 minutes comfort break and come back for a Q&A, refreshing Q&A. Is that okay? Yeah. Thank you very much. So back at 4 o'clock, please. Thank you. For me, as a cardiologist, a non-nutritionalist, but with an interest in it, there was a lot of it I think we could take from this afternoon. I think certainly what I gathered, almost starting from Norlaila, that what is amazing is Malaysia collects a lot of data. Without data, where do you go? So I think we're blessed to have that data. And I mean, there's a lot there, but it's the scale of the problem. And over the years, it's getting a bit, if anything, worse. So then we have heard solutions, proposed systems. Then we've heard from Sanele, from certainly the ASEAN region, there's a lot of gaps, knowledge gap, that we don't have enough nutritionists, we need more training. And then, of course, we've heard the exciting program from NNEdPro, what's happening. But maybe if I can throw it to the nutritionists here and at a local level, you've seen it, you know the scale of the problem. I don't suppose we can overnight solve the problem, but can you suggest some areas that they think that we should be thinking about? Surely the government must see this, must be hugely frightened by these numbers. But what are possible solutions out there? And how can organizations like NNEdPro and the initiatives we hear from, how do we do this? Over to
Right. Before you throw the thing back at me. Well, I've seen patients who already had diabetes and complication. And what led to that is the diabetes actually is, I think, more of one could be lack of education from nutrition point of view, because what they always tell me is, I don't take sugar, but they actually eat a lot of carbs, like mee goreng, nasi goreng, basically carbs and sugar, carbs and fat. And they eat big portion. So the portion as well as the quality as well as the quantity. So unhealthy and a lot. So that's back to education. And I think schools, it all starts at school and at home. Because it's all different idea that they have. So that's the one. And prevention, that also lead to prevention of diabetes before they get diabetes. And when they have diabetes, once we start them on medication, the thoughts is always, now I'm on medication, then I can eat whatever I want, because now I have tablets, or I'm on insulin, I can increase the insulin dose and I can eat whatever I want. So that's always the idea. So go back to education, and I think education from my part as a clinician, as well as a lot of input from nutritionist or from dietitian. So, once they're diabetic, then, I need a dietitian. Otherwise,
and are you
nutritionist.
referring to the dietitians?
Yes, we do refer. But it's not.
Is the rest of Malaysia referring to dietitians?
So each clinic, they have dietitian. Even clinic kesihatan, they have dietitian. But I think it's still not enough, because I do go and to Seremban to give talk about, that obesity, give them the CPG obesity. Still, they don't have enough dietitian or
So they don't have
nutritionist.
enough dietitians.
Yeah. Yeah.
So I'm working in a primary care in Perak. So for my district, we only have nutritionists. There's only one dietitian covering the whole district.
The whole district?
Yeah, the whole district. And she's in the hospital. So she does not cover the primary care.
So the primary care clinics, they have no access at all.
No.
And is this because we We haven't trained. Is there a
I
plan
think
to train more or not?
they are training, is just not being sent to rural areas yet.
So,
Yeah.
okay. Yeah, if I could just
Yeah, please.
So I just wanted to kind of bring us back to the top because obviously we've had a whole range of presentations. We've talked about global, local, regional. But I think that as today's kind of umbrella is systems thinking, what I'd like to do is for us to try and think in frameworks. So one thing I wanted to say at the beginning is that as healthcare professionals, we tend to work very downstream. We think about how to impact food choices, how those food choices will impact nutritional status, and how that in turn will impact disease or health outcomes. But I think what we do need to do in systems thinking is think upstream and think about food production, food supply, the food environment, and all of the different influences that sit between those components of the food supply chain and food choices. Then, of course, once we come to food choices, there's heredity, environment, lifestyle, socioeconomic circumstances. All of those provide a kind of unique filter through which people's food choices need to be best matched to their individual circumstances. So again, at population level, whether it's using the results of surveillance, as you nicely showed in your presentation, or whether it's actually using other types of insights, being able to actually stratify the population to identify at-risk populations and to think about sort of primary prevention through a specific protection approach, that would actually give a lot more precision because at the moment, primary prevention in the majority of countries and potentially across most ASEAN countries may be much more about health promotion. And with that health promotion comes the challenge of how people can contextualize it to their individual circumstances, but also their sociocultural requirements. And then the massive economic and political forces that are coming from food production, food supply, and the food environment, including the impact of popular culture, advertising, and other types of media influence. So thinking of the whole system, I think that healthcare professionals, even if they are clinicians, and even if they are working more at secondary and tertiary prevention level, it's really good to see nutrition professionals as a way to think upstream and downstream, because generally in most parts of the world, dietitians work with those individuals who already have established risk factors and already require kind of disease-specific nutritional planning and intervention. But working with the entire community of nutritionists and dietitians gives that sort of lateral scope to think about how to segment knowledge, as I was saying, in terms of primary, tertiary, and secondary prevention rather, and to actually bring some precision into it. So I mean, there may be other general points and questions that you have just now, but Helena has prepared a few kind of questions relating to type 2 diabetes prevention and systems thinking, which would be wonderful to ask everyone. And Sanele has prepared a few questions with regard to the nutrition education pre-service, nutrition education competencies, because actually the pre-service nutrition education competency framework could be one of the main tools through which professionals are informed and empowered to actually take some of these steps. And then that needs kind of support top down from policymakers, which is where the government or ASEAN governments come in. And of course, it requires bottom up support from patients and the public. So I think the starting point may well be getting this kind of curriculum framework right, because that can then be the hub and spoke from which other kind of pieces of implementation arise. So I just wanted to say that to set the scene, because I would love for today's discussions to give us something tangible that we can work with as a blueprint for collaboration.
So, yeah, please.
Totally agree.
Maybe close. Yeah.
Closer, thanks. On the issue of not enough nutritionists or dietitians, if you look at it from a systematic approach, let's go upstream. It's not because we are producing less graduates who are nutritionists or dietitians. It's because the environment that these countries operate in, they are overwhelmingly employed by the public sector. In the public sector, the government goes by allocation of positions. So in Malaysia, we call it warrant. So if you don't have an allocation means that the government is committed to hiring that person on a permanent contract and has provisions for that person's eventual pensions. So when the government does not have enough warrants for hiring such positions, so irrespective of how many graduates you produce, there will not be anybody to fill. It's not a case of nobody to fill the vacancy. It's a case of that position is not created. So to give you an example on the impact of that kind of action is 20 years ago, where I work in Sabah, Universiti Malaysia Sabah, Malaysian Borneo. So 3 districts, Tuaran, Kota Marudu, and Kota Belud, share 1 government nutritionist. What is the size of 1 district? 1 district is the size of the country Singapore. So you are talking about 3 districts sharing 1 nutritionist. Yeah. That's an impossible job to do. So that was 20 years ago. So after that, they revised the policy. So the country now has, the state now has 1 nutritionist per district. So there are about 28 or 30 districts. So now we have the same number of nutritionists per district. So 28 to 30 nutritionists, 1 in each. So it's much better. But of course, we are rectifying the problem, but we are not really at a place where we are happy that with the number of nutritionists. Actually, the country does not have the I can't remember off the top of my head. You have a ratio of how many physicians to the population. You have a ratio of how many nutritionists or dietitians to the population. We have not reached that yet. So now you go back to the same systems. So the alternative would be, why should we rely only on the public sector to hire and to make available nutritionists and dietitians? Well, the fact of the matter is, if that person is to be hired by the private sector, who would like to pay for that consultation? Many patients, either they are the lower 40 percentile of the socio-economic the economic household income bracket, so they wouldn't be able to afford that kind of consultation fee. That's one. So those who are in the upper 20 to 30th percentile of economy, you could provide education, and you could think of strategies to make sure that they are more aware of that they wouldn't mind paying for that consultation. But in a country of 32 million people, I don't think any private sector would like to have massive hiring for dietitians or nutritionists to serve the top 30th percentile of the population who might be persuaded to pay for that kind of consultation. So it's a case of you need the services, but you don't have the ability to hire to provide that kind of advice. So when doctors want to refer, there's nobody, like overload.
But
right?
Can I ask something just out of ignorance? So if the public sector absorbs most of the graduates, so I understood the opposite. That's what I was not understanding. Okay, so the number of hires from the public sector is very low for nutritionists.
There are 550 public sector. Around somewhere between 5 to 800, if I'm not mistaken. Yeah.
Okay.
Yeah.
Because I was understanding
so
the opposite. It was not making sense. Okay.
So they have, but actually the the numbers that we should have in our country is closer to 1,000. Yeah, 2,000.
At the moment, in terms of public sector hiring, is about 800.
Right.
So way, way below.
But also, sorry, just a couple of things. So there are some points and questions coming through online from Zoom. So Sanele from UNICEF says that, just to add, that Malaysia is in a much better position amongst all of the ASEAN countries. So also, obviously, as you know, we are thinking on a regional basis. I think that particularly in terms of dietetics distribution, some of the regions have absolutely no framework. But a personal anecdote that I want to share is that so I spent the second decade of my life in Brunei, and my father was working there to set up gastroenterology services, which was a new thing in the kind of latter half of the 80s, first half of the 90s. And so obviously they used to work with dietitians. And back then, the district of Belait, where we were, so they had only 2 dietitians. So I went back to Brunei as a visiting professor in 2017. And so I asked them, so how many dietitians you have in Belait now? They said, oh, now it's like, you know, much more improved. And then found out that they have 3 dietitians. But in a country like Brunei, which has unlimited financial resources, I don't think it's a financial issue. I think it's an awareness issue. Because when I visited Kuala Belait and I just spoke to people and they said, actually, because we don't have enough capacity here, we send people to Miri across the border to Malaysia. And then because, you know, the Brunei government is supposed to cover health services for its own population, they pay large sums of money to the hospital in Miri to give people vouchers to go and get this service. And the hospital in Miri is very happy with that because obviously they are making some money from it. But I think that this is not a resourcing issue, it's an awareness issue, which is why I do think that policy dialogue is one of the ways forward. So I just want to ask what the opportunities are for policy dialogue.
Can you speak up, please? Might as well leave it on, honestly.
Okay. Yeah. So I think in Brunei, the problem might be that they don't produce their own nutritionists and dietitians. So I know of some of our dietetic students who have graduated from UKM and they go to work in Brunei. So they might have difficulty to hire this sort of service people. Yeah. But policy dialogues among the Southeast Asia region countries might be a good idea. Brunei is not the only country that doesn't have nutrition or dietetics degree programs. Singapore now has. Yes, they have now in SMU, Singapore Management University, yes. But I think Laos or Cambodia also doesn't have. Sanele is right. Yeah, there's a lot of lacking in Southeast Asia region.
I would like to continue the discussion from policy dialogue with governments to how we teach nutrition undergraduates. So I did my PhD in King's College London. So during my time there, I know the Brunei government sent their students who wants to do nutrition or dietetics to British universities. They send some to Malaysian universities. Now, the quality of education is of no doubt at all. The scientific merit of such degrees are of no doubt at all. But the issue is we need to deal with at a multi-sectorial, multidisciplinary manner. What I'm saying is, because I teach in the first semester, I teach nutritional and epidemiology. In the second semester, I will teach nutritional anthropology. So I could show the students from an epidemiological sense right to the anthropological sense. So, meaning to say, nutrition students, undergraduates, must be taught how the food culture of that place. So you cannot export your student to a very highly ranked university and hope that you produce the best nutritionists to serve your community. So you don't learn the intricacies of food culture, food beliefs. It is almost impossible to get people to do what you advise. So I think that is the second thing. So when we want to talk about awareness, decolonizing, yeah.
So during the coffee break, we talked about, like you say, upstream, and in terms of sugar tax, in terms of food production at a nationwide level, we don't think at the moment we've got it right. The sugar tax doesn't affect everything. We don't cut down on. Please, can you elaborate on what we talked about?
Thank you, Prof. Just over coffee break, we spoke about the obesogenic environment that we are not controlling. For example, Malaysia, for example, levies a sugar tax, but that is only on factory-produced drinks, sugar-sweetened beverages. You can't tax sugar on your kopitiam or your Starbucks or whatever expensive coffee, all right, and boba drinks and whatnot. So that's one. We also have, contrary to public health evidence, we also subsidize sugar and cooking oil, which contributes to a cheap way to achieve high energy intake over a long time. And that breeds, the kind of food habits and sorry? Sugar, definitely not. Cooking oils, I don't think they're fortified. The more expensive ones are, but no. So that's one. The other one we were talking about was the lack of control on 24-hour eateries. So you could eat 24/7, literally. And so again, we are creating an environment where it is cheap and easy to have access to high energy intake. And what are the major components of the food usually sold or available at such 24/7 eateries? They're high carbohydrates and high fat, high fried foods, high sugar foods. So how much sugar? So for example, the Malaysian teh tarik, tea with sweetened condensed creamer. You're probably thinking about 3 tablespoons of sweetened condensed creamer in an average cup that is about 250 mils. That's quite a lot. So if you have 24/7 eatery and that person consumes that 3 to 4 times a day, and it costs what? In Peninsular Malaysia is about 2 ringgit to 3 ringgit. Sabah, it might cost you 350, but relatively is quite, Malaysians would say it's expensive, but relatively you're talking about something that is less than £1 or $1. Relatively cheap to be consuming that amount of, simple sugars and high energy.
Yeah, sorry, just like I said just now, my patients, they always complain that a good nutritious food is always more expensive. The cheaper one, is always, high in carbs, high in fat, and that will give that will give them energy, and they feel full, and they will go for it.
So this is why, again, I've put up this slide, this primary, secondary, and tertiary prevention. So I talked about health specific protection and knowing more about how to make nutrition more personalized and precise. But even in health promotion, I've put there literacy and health literacy, under which, food and nutrition literacy is a subset which we cannot assume, even for highly qualified professionals, whether they're clinicians, policymakers, whoever it may be. So this is one of the reasons why I think that the model of the mobile teaching kitchen may have some traction in Malaysia, because just yesterday I went to Malacca, and on the way and there and on the way back, I observed the number of mobile units that are, it's so many different types of mobile units. And even after coming back to KL City, I looked at other mobile units that they're all very different. They all adapt to the places and spaces that they have. But it's incredible. So that's part of the 24/7 that you were talking about. But then disrupting that by demonstrating to people that they can actually sell very tasty, fresh, healthy, low-cost foods, which will still bring the vendors as much revenue, maybe more revenue actually, if it's done well, but at the same time, absolutely kind of reduce to maybe 25% the unnecessary calories from saturated fat and also from carbohydrate that is not ratio matched to micronutrients. That can be achieved. And I think that one of the problems is that, you know, the State of Food Insecurity report of the FAO and other documents, they have published, based on very high level data from very few countries, statements such as it is very difficult to eat healthily on low cost. Yes, it may be challenging, but it's an awareness issue, and it's about people going back to knowing where and how to find different foods which are sustainable and low cost. So what the mobile teaching kitchen model does is, behind the scenes, there's a group of researchers who are looking at the environment, actually understanding, you know, what foods are available, what the carbon footprint is, what the production cost is, and also what the nutritional values are. And then they're taking popular recipes. So, for example, could be nasi goreng or could be satay. But
I mean, on that note, I mean, it's all very well, but I mean, I want to listen from at a ground level how.
What I want to understand
No.
is that possible to take popular recipes and actually convert them by doing nutritional disaggregation and reformulating them? Because this has been done in 4 countries. So is that possible in the Malaysian context?
Nutrition Society of Malaysia has been, for the past 20 over years, promoting healthier recipes on very much well-loved Malaysian food. The people who are health aware would take up those recipes, but people who again, you come back to nutritional anthropology. We have to know why they prefer food that is fried and high carbohydrates. And not only that, like I think, Doctor, you showed the plate of the typical Malaysian food. You have very little protein, very little vegetables, but a lot of carbohydrates, be it rice or noodles or dosai or chapati, you know. And from a nutritional anthropology point of view, it comes from our culture that we were poor once. And it also ties in with your B40 group. They are the highest, 60% of diabetic patients are B40, the lowest 40th percentile of income groups. The reason is, when you're poor, carbohydrates are the cheapest. So for you to make the most out of your money to alleviate hunger, that's how people grew up. And when you grow up like that, even when you have money, you have the means, you still tend to eat like that. An example would be my father. He grew up in a low income situation. So now that he has no want of money. I mean, you know, we are blessed that he's not in a situation where he has to think how much I had to pay, you know. But still, out of habit, and he's a diabetic patient, and out of habit, he will still consume a lot of carbohydrates, rice, and with a little bit of protein accompaniment, out of habit. And daughter is nutritionist. So, old habits die hard. So, it took me 20 years to tell him, Pa, you should eat more protein. How much more? Take 1 whole drumstick. And then he looked at me, it's like, 1 whole drumstick, 1 person. Isn't that a bit exorbitant? So this is the kind of idea that we had. He grew up, I mean, he's 78. For the first 20 years of his life, he grew up poor. So you need that kind of nutritional anthropology in your nutritionist and dietitian to how to advise patients that, what your comfort zone is, you need to move out of your comfort zone.
And Prof, just on that note, would you say sometimes in some contexts, within my own family, for example, we observe that patients or people in general who are economically deprived in the beginning of their lives, sometimes when they are better, they crave for the type of things that they could not pay, especially in terms of processed foods. For example, in Portugal, where I'm from, you would see that people like my mother or my grandmother, they would not have access to some type of processed foods like chocolates or some types of bars because they were expensive. So when they had access, even if they could make a healthier snack, it would give them some sort of gratification to acquire a more processed food. I don't know if the same applies here, or that's very interesting.
Pattern that, right?
I think what Yasmin said just now is right in the sense that our food culture is so strong. Although now there's a mingling of Malay, Chinese, Indian cuisine, and we all eat each other's food, but how we eat tend to be a bit traditional culturally. And in those days, you said people were poor, but they were not only poor, they were the farmers, they were going out to the sea, they were working in the
So they had high
farms.
energy expenditure.
So they had high energy expenditure, so the high carbo was fine. But today, all of us are sitting around.
So
yeah.
I need to now engage the people from UNICEF. They have some questions that is a deliverable. So these are some guiding questions from where you're sitting. You can look ahead that side. Relevant to practice at entry level practice. So reflecting on your early years of medical practice, which nutrition competencies do you believe should have been prioritized during pre-service training to better prepare one for nutrition-related issues that one encountered in clinical practice? So which nutrition competencies do you believe should have been prioritized? So they want to engage from at the Malaysian level.
So if you like, I can just take the slides back to those competencies to remind people what they are. So scientific principles, nutrition assessment. So obviously the screening, and then screening helps to identify those who are in need of full assessment. That can help with nutrition dietetics referral. And then there are competencies around nutrition care and medical nutrition therapy, and competencies around public health, nutrition, and food systems, which is what I think we have been discussing. So just going back to these questions. So Sanele is online and I think she can hear us.
Yes, I can.
Sanele, do you want to add anything to this? Chim has already outlined the first part.
No, thank you for the opportunity. I think that was the question, but I guess I'm just reading from the audience that we probably have a lot of dietetics people in the audience, and I'm wondering because we were thinking of this question from the medical perspective. So another way to look at it is just to ask, especially for situations where there are no dietitians, as we've been explaining that there are a shortage of dietitians even in Malaysia. What are then the roles of other health professionals in nutrition? So what is the practice and what do we see should be prioritized? Let's put it that way,
And
including the
Professor
competency.
Mustafa can also comment from the medical perspective.
Sure, yeah.
Right, thank you. Because I run a diabetes clinic as well as obesity clinic. And regardless whether they are diabetic or whether they are obesity, we always ask about their diet. Because even if they're diabetic, anti-diabetic can cause hypoglycemia if they don't eat properly, or if they don't, they overeating, you will not be able to control their sugar level despite on insulin and all the other medication. So of course, the macronutrients, the carbs intake, as well as fat and also protein intake. We try to do that as frequent as we can, and very detailed. We will then ask our diabetes educator, which are trained by our nutritionist and dietitian, as well as refer them to dietitian. So in every clinic visit, apart from asking about the medication, the control, diet is always an important question that we ask our patient. That's how I found out that the problem in terms of understanding or misunderstanding by patient, and it become like a second nature to them, that I do this, they do the wrong thing right from the word go, right from the very beginning, or the other option is, the other thinking is, I'm already diabetic, so why should I change? So that's another misconception from patient. Although we try very hard to do that. And of course, like I said, the main issue is the availability of food that is affordable to them. Because they still have to buy some of the medication, they still have to pay for the lab tests, and also transport to come to see the specialist. So that are the issues.
And just thinking back, looking at the second part of these questions, I mean, and just thinking to the medical education of other clinicians, physicians in Malaysia, do you feel nutrition was given emphasis? How can it be emphasized more?
Frankly speaking, no, because I think a lot of my patients said they are very scared if they see me, because I'm very strict in terms of medication, in terms of diet, as compared to the junior doctors who will keep on prescribing medication the moment the sugar, the diabetes is not well controlled. So the aim is to treat or to hit the lab parameters to target without actually asking whether they take the medication, whether they're controlling their diet, whether they're actually exercising. So a lot of junior doctors, unfortunately, still rely very much on medication without probing very much into the nutrition as well as cultural aspect. I can ask patients who's been eating rice in the morning since the day they were born, to stop eating rice as breakfast. But what I tell them is, in the past, our ancestors, they work as rubber tapper, they work as fishermen. Now you work in the office, so you have to think whether you need that much calorie to keep you going for the day. So it's more of a discussion about how much goes in, how much calorie goes in and how much actually comes out. So you have to educate the patient. It goes back to education, but it will take a lot of time on my part. But, got no choice. We still have to do that.
So I was going to ask, because I don't think at medical school, whether we spend enough time to educate our...
Yes, no. Unfortunately, no.
So therefore, it's something that at curriculum development, and knowing how big a problem this is, should we increase the amount of teaching on nutrition, but without at the expense of, because the curriculum of 5 years is so tight, so you don't want to increase it, but at the expense of teaching in psychiatry or whatever. So therefore, this is at a very high level in terms of training of our future nurses, doctors. How much teaching should we have on nutrition? And to answer Salini's question, I think at the entry level, at least recognize the scale of the problem, recognize what is deliverable, but also teach them to refer. If as a graduate doctor, graduate nurse in the clinic, out in the community, if you struggle with pre-diabetes, diabetics, obesity, think about referral, isn't it? The whole journey of a patient from at risk to become a diabetic, to comorbidities. But we should certainly teach more, I think.
Yeah, I agree. Yeah.
In UKM, I think they do have maybe like 4 to 6 hours
Well,
of
4 to
nutrition.
6 hours of lectures,
Yeah,
general
yeah, yeah, yeah.
lectures,
Yeah.
as what, I'm
Yeah.
supposed to teach the nutrition student on diabetes,
Yeah.
metabolic syndrome,
But
and so.
maybe as part of CPD, and all doctors Malaysia needs to do the CPD,
Yes.
then throughout at every level, undergraduate, postgraduate, continuing, emphasize that rather than in addition to whatever, I think is important. Yes.
Maybe I can add, yeah, I do agree that maybe in our undergrad medical studies, nutrition is quite lacking. But I think from the coming years, like we see in our guidelines, clinical practice guidelines in type 2 diabetes, even in obesity recently, we are seeing more of nutrition being part of the therapy itself. So we are using it as medical nutrition therapy. We are starting to actually counsel patients based on nutrition and making food as medicine. And even lifestyle medicine is also coming up. So I think there is a shift. It's not like, even though we do not provide it in curriculum, but in our guidelines, it has already been established.
Yeah, I think we cannot divorce nutrition from how we look at things, no matter how your approach is. But on a systems approach, I'd like to bring us back to how we teach medical students. So like UKM, I'm from UMS Sabah. We teach 4 to 6 hours, on average 5 hours in a 5-year curriculum. One might on the surface say that that would not be enough. I would agree, because we need 4 years to teach a nutritionist or a dietitian. So there's no amount of hours that you could increase in a medical curriculum without compromising on all the other equally important medical disciplines, of which you want your doctor to be well equipped to do. So may I suggest that we provide within the 4 to 6 hours the basic nutritional sciences, and most importantly, which we don't provide our medical students, and I know because I teach nutrition to medical students last time. I stopped doing that now because we got other people to do it. So when I was doing that, I realized that the medical curriculum did not have an emphasis on research methods and evaluation of scientific literature. It is very focused on this disease, how you treat. This is the etiology, this is the pathophysiology. So it's drilled into medical students, and rightly so. But I think they could really benefit from evaluation of literatures. The reason why I say this is over 30 years of practice, I find that I have medical colleagues who come and tell me, oh, I am going to tell all my patients they cannot drink milk. Why? Because it causes terrible inflammation. It is so people who know and appreciate literature will see that, yeah, you probably find 1 or 2 papers talking about that, but within a certain context. But that is not for you to go and advise every patient to stop drinking milk and then deny your patients the benefits of consumption of dairy products. So I think and doctors, anyone who can pass medicine are intelligent people. So if you gave them the basic scientific evidence, the appreciation of that, appreciation of literatures, I think throughout their careers, they must attend CPDs. So I think that will sort itself out. And beyond that, studies have shown that medical students who have been exposed to some form of nutrition education are more likely to make referrals to nutritionists and dietitians. I think that's all I want to say. Thank you.
That was really useful. I think Salini, was that loud and clear for you?
Very loud and clear, actually. Thank you. Very useful. I actually had a follow-up question, not necessarily to you, because I completely agree with what you're saying, that evidence-based practice is important and learning, how to appraise literature and stuff. But, we've been talking about the hours, right? So there's not enough time for nutrition, 5, 6 hours for nutrition. But I was wondering that, how about integrating nutrition into existing courses or existing disciplines already. So when you're learning endocrinology, for example, isn't there a space for a little bit of, okay, but these are the nutritional things that you can look at. So I want to know, what is the experience? Are we really counting the real amount of nutrition if when in a medical curriculum, if what I'm trying to say is that, if we're saying it's 5-6 hours discrete nutrition, maybe that's the discrete nutrition, but then we also have, subjects where nutrition may come in where we're not necessarily counting that. So that's my first question. And number two is, what is the opportunities do we think then that we can integrate and make it, just sandwich it inside, existing disciplines, to make it not seem like it's one standalone subject that we have to have 30, 40 hours of teaching on, but it's just integrated.
If I could just put an information rider on that question. So it's exactly due to that reason that if you look at the AFN curriculum for medical nutrition education in the UK, which we are now negotiating with the General Medical Council on, because there's a medical licensing assessment which will be coming into effect. So we will, for the first time ever, have nutrition questions. So assessment guides the curriculum. So now all medical schools will have to implement it. The reason we collaborated with Kumar and Clark's Clinical Medicine to publish this guide is because we've mapped it to every single system. So when doing cardiology, if people spend 20 minutes, in their PowerPoint presentations highlighting the nutritional issues, same when doing endocrinology and embryology, we've actually created those maps. It exists, and that experiment is about to happen for the first time in the UK, but also in 5 other countries. So theoretically, at the high level, globally, there is a roadmap for it. But now coming to the kind of Malaysian or Southeast Asian context, do you see any kind of levers or opportunities to implement that sort of thing in the way that Sanele described, and maybe using some of these roadmaps that have been developed?
Right. Yeah, definitely. Because in the past, obesity is not part of curriculum, right? So now we are actually putting in obesity, because obesity is a disease and that leads to diabetes, cardiovascular disease, and so on, as part of curriculum, and it's gonna happen. So with that, I think it's good to have nutrition, like what you suggested, and you suggested as well as part of it, because yeah, I like to read Kumar and Clark last time, as my reference, apart from Harrison and other books. There's no, when you talk about disease and pathophysiology and the treatment, it goes straight to pharmacotherapy, and there's no lifestyle like heart failure, salt
Absolutely.
intake and so on.
But I think with pressure, I think that's going to happen. I think at the moment there's intense CPD programs around obesity. And I confess, I've seen it where they pay lip service to lifestyle intervention, just lip service. And sometimes I've even seen it to say that lifestyle intervention is poor adherence, poor compliance, and it rebounds the moment you stop doing it. But that lip service I think, is not good. I think we need to say that lifestyle intervention is a cornerstone of therapy of obesity or diabetes. Cornerstone. On top of that, pharmacotherapy. But that message needs to go out there at all levels. But yeah.
So I know there are a couple more questions online, but I'm also wondering if Helena has anything to add, because I know you'd prepared a list of questions.
Oh, I've been absorbing everything, which has been super useful. And I would just one question that I think sums it up, and I think would be really useful for me, would be understanding if you think about the development of the disease, what would be the key factors? I'm not speaking in terms of the sugar intake, but like overall, what would be the key factors that you identify that contribute more to it? Would it be lifestyle in terms of time that the person can spend to cook? Would it be access to education? Would it be socioeconomic capacity for the buying of food? What would you identify as key factors?
Barriers. Are you talking about barriers?
Whether it's factors or barriers, in my opinion, it would be the knowledge of cooking and preparing food for oneself. In the name of modernity, we, as the younger generation, have kind of lost that knowledge. I mean, 2 to 3 generations ago, you could hardly find anybody who could not prepare or make their own food. But today, it is highly possible for someone to not be able even to make a beverage for themselves. So, when we chase development and modernity so much, so that we've somehow kind of lost it. And that kind of education has also lost popularity in certain school, primary and secondary school curriculum. And sometimes it's seen as that's the, I'm sorry, excuse me for the word that I will be using, but that's the feeling people get. I'm put to the dumb class because I'm in the class that will be teaching cooking skills, the smart class goes on to do technology or commerce, that kind of thing.
If I can just add also as a student in school, currently, my school does not have, we do not have cooking classes. And I don't think we have for a while. It was traditionally an all-girls school, and we did then, but we have no way of learning cooking within our school, which I find to be shocking. We are one of the best schools in Scotland. We are an international school, and we pride ourselves on having a holistic education, but we don't provide a holistic, and our school motto is ad vitam, Latin meaning for life. What about life does not include cooking? So I just want to add that's truly relevant, and globally this is an issue where home economics is being I mean, it's not just the sewing and the woodwork and all that, it's cooking is an essential part of this. So yeah, I just want to say that is completely relevant, like globally.
So actually, to add to that, this is why with their school, we've agreed a collaboration where the University of Malta, which is highly experienced in home economics for boys and girls across all Maltese schools. So the whole population of Malta, they cannot graduate from school without learning how to cook. So they are bringing an event to Scotland as part of the summit, which is a global youth essay competition and festival of ideas. It's hybrid. So actually, we'd love to share information about that. And if we could get Malaysian schools to enter and participate, that would be amazing.
Absolutely. And it's a very relevant point because young people now don't cook. They don't know how to cook. Food, like you say, this kind of obesogenic food is so readily available and cheap. So they need to be, I think it's a good point. I think train them young and then, at a school level, will be.
And the only reason why I know how to cook is not because of people in my generation telling me, is my grandma. I've learned all of my cooking from my own grandmother, who grew up in a compound family in Kenya with everyone around, and they had no option but to cook. They curdled their own milk, they made their own butter, they made their own ghee. They did so many things from scratch, which have been lost. And if I didn't have my grandmother, I wouldn't know ways to cook, actually. So these things are being lost through generations. So yeah.
Yeah, I think I'd like to introduce the intersectional issue of gender, because just now we were talking about younger generation beginning to lose the skill of cooking and preparing their own food. But even if as a society we agree that we should teach the young generation to cook and prepare their own food, there is the issue of gender, because many of our societies, especially in Asia, Malaysia included, are very patriarchal. So the idea is, let's send all the girls to learn how to cook. So
Really?
if we have
I
that,
love cooking.
if we have that approach in our policy, again, we would not be successful. We'll be probably 50% successful. But I'd like to take this opportunity to come back to Sanele's question, which was, do we think that is a good idea for you to, and your question to Prof, do we think is a good idea to embed, say, 10 minutes, 20 minutes of nutrition instruction in various medical disciplines? As a nutritionist, I think it's a good idea because the first port of call is often the physician. Patients go and see physicians first. They don't usually walk in to see a nutritionist or a dietitian. So having a physician who is very in tune with the role of nutrition in preventative health as well as in treatment, that's very good. But I would also like to stress the point that physicians must, beyond the initial consult and to lead the patient in the right area with the right set of mind on nutrition and how it's going to impact their long-term health, they must make that referral. Because a physician, unless you are, like Prof, you're running an obesity clinic, yes, or you're running an endocrinology clinic, yes, then you deal with a lot of times we deal with food. But in many other disciplines, you have a lot of equally important issues with patients to tackle. You don't have the time, the luxury of time to go and consult your patients on matters on nutrition and dietetics. So I think that ingrained professionalism to make that referral is also very important and must be stressed.
And actually, for 10 years, I was a curriculum director in the School of Clinical Medicine at Cambridge University. So during that time, we developed and ran a nutrition curriculum for the first time ever. And the way we did it was we borrowed time from public health, from gastroenterology, from endocrinology, and also there's a little bit at the end which is called preparation for practice, which is when these terrified medical students come and they're like, oh my God, we have to actually practice. So we did it in that way, and we made it very interactive and fun. So for example, we brought nutritional supplements to the sessions. We got the medical students to taste them, and then eventually what happened was lifestyle medicine was born during that time. And then this whole thing got subsumed in lifestyle medicine, and it's now everywhere across the curriculum. So in a way, we did our job over 10 years in a way that we became redundant at the end, which is actually the way to do it because it's to become incognito. So people are not thinking of nutrition as an additional headache to incorporate in the curriculum. It's actually everywhere but nowhere, but in a way that works. So I feel like that can be done, but we maybe need, allies from the different ologies like cardiology, endocrinology, gastroenterology. So I wanted to ask, is that possible in the Malaysian context? Can we get those types of specialists together to collaborate?
I think it should be explored, most definitely. Just before, I know we're coming now to 5:15. There's a question from Mustamina to everyone, and it says, could you share the significant methods or approaches that correlate with traditional medicine health supplements with patient nutrition? So this is a question around traditional medicine health supplements. Is this something that comes up, or I don't know? You see, do you want to comment on that? Please.
Interestingly, my colleague recently did a survey of pre-dialysis patients, CKD, and their use of complementary and alternative medicine. So in Malaysia, like in many developing and newly developed countries, many patients resort to CAM because number one is the culture, the culture that they're brought up in. Number two is it is perceived to be cheaper than going to see somebody who's a doctor or a practitioner of evidence-based medicine. Number three, they think that this is much better than taking synthetic chemicals as prescribed by the physician. So whatever it is, the finding is that we must recognize what are the CAMs used we as health professionals, we must know what is the nutrient-drug interaction, drug-drug interaction from those CAM. And we must encourage patients to shed the guilty feeling and full disclosure with their health practitioners on what type of CAM they're taking, because otherwise it will definitely impact on the outcome of their disease.
The Indian government 4 years ago integrated everything into one ministry. I don't know if you saw, but medical doctors protested. They were on the streets everywhere. But now it's actually working quite well because there are randomized controlled trials being commissioned for all Ayurvedic medicines where there is an evidence gap. I mean, there's like 50 years of catching up to do. Do you think that can happen with TCM as well?
I think China and Taiwan have been very successful with that. And in their public-run hospitals, these two traditions are practiced together. And CAM, if practiced correctly, is actually evidence-based. It's just not Western tradition. So I think we should appreciate it for what it is. And by appreciating it for what it is, then we can root out the myth peddlers, the hope sellers, and basically anyone not trained in an evidence-based tradition, whether that would be Western or Eastern.
I'm mindful now it's 5:15. Wow, I think that was a very lively discussion. I think there's a lot of, for me, really a lot of great take-home messages, a lot of action points. And I want to thank everyone who's participated, all the speakers, even from the floor, and a really outstanding session. I think to show our appreciation to everyone, thank you very much.
And special thanks to Professor Chim Lang for bringing us all together. Thank you. Thanks, Sanele.
Thank you.
Is it possible to get people
Sanele,
on
don't
Zoom
leave
in the
yet, so we
background?
can just,
Yeah,
have Sanele in the background. Yeah.
Okay. Can we get all the people on Zoom in the background to unmute their cameras and we'll stand beside the screen and get a photo?
Go behind.
No?
You're all photogenic. I'm also photogenic. Come, please. Yes.
Sorry, I'm just gonna go. But I should be there otherwise. If you could come in front slightly. Get everybody. Yeah. Okay, Polly. One more. Thank you. Thank you. Thank you. Thank you so much. Really wonderful. And do any wish? That was fortuitous. Are you joining us? Yeah, huge pleasure. And you add global. It's normal. UKM. The main session. Yeah. I'll see what I. But also, it's just saying it's great that people need. I love the language. So I think organize. And there is some other. Yeah. Thank you. Like